Well, good morning, everyone. It's Eileen Bird, the Executive Director here at 2Life. And I'm joined by a number of people. I'll do introductions, but I want to say welcome to the 2021 Women's Health Conference, Informed Engaged Treatment and Informed Survivorship. Today's talk is going to be the last in our series of 6 presentations that we've done starting in the November timeframe, and it doesn't seem possible that we're actually on January 26th and a snow day as it looks like it's going to come out. And so I want to thank you all for joining. As you will see as you come in, and if you're hearing my voice, you've been entered in a mute without any audio mode, and so as we go through, we've got a few people that will be having speaking roles here this morning, and we will invite you to put questions and so forth into the chat box or the Q&A box that you'll see if you hover your mouse over the bottom part of the screen that you see here. And so today we're going to talk about metastatic breast cancer and emerging treatments in breast cancer. When our advisory board put this particular series together, we wanted to be sure that we addressed topics that were of interest and a need to know for a survivor community. And in particular, this talk, which has an awful lot of science and information attached to it and of interest to people, but presented by someone who is both knowledgeable in the science and in seeing patients. And so Dr. Kahn, brings that wealth of knowledge and perspective to today's talk. So we're very excited to have him present. So I want to keep going on here. Our sponsors have made today's program possible, and I want to call them out: the Department of Health, New York State Department of Health, Mona Corporation, Genentech, and Saratoga Hospital, and Repeat Business Systems. We are so grateful for their sponsorship and happy to have them partnering with us. So Dr. Kahn is the Medical Director for Medical Oncology at St. Peter's Medical Oncology Hematology, a practice of St. Peter's Health Partners Medical Associates. Dr. Kahn received his medical degree from St. George's University School of Medicine in Grenada, West Indies, which is probably a little warmer than it is here today. Completed his internship and residency in internal medicine at Drexel University School of Medicine, and completed his fellowship in hematology and medical oncology at Newark Beth Israel Medical Center. Fellowship trained in hematology and medical oncology, Dr. Kahn is also board certified in internal medicine. He practices hematology and medical oncology, and his professional interests include both breast and lung cancer. And so, Dr. Kahn, I'd like to welcome you, and the forum is yours.
Eileen, thank you so much, and good morning to everyone, and thank you for the organizers of True to Life. So it's a great pleasure to be here and to present the topic of metastatic breast cancer. So we'll certainly take questions, as I explained to Eileen earlier, that I'd be more than happy to answer them. So moving forward with our slides here, first off, let me share. Do I need to share my screen there? Here we go. Let's see if I can, I'll just bring up my, let me just bring up my topic here 1 second. So speaking of metastatic breast cancer, particularly with this topic, I wanted to talk more about the emerging research that has gone on over this past year. And just to give you a small overview of metastatic breast cancer and the way medical oncologists manage it in the day-to-day practice, particularly how I approach it with my patients day-to-day as well, is looking at 3 different subtypes. One is obviously the ER-positive, HER2-negative breast cancers. The second is HER2-positive disease. And the third is triple-negative disease, or ER-negative, HER2-negative disease. And I think we should get it here. So on the topic of metastatic breast cancer itself, stage 4 breast cancers, generally speaking, are cancers that have spread beyond the breast and axillary nodes, and today account for approximately 10 to 15% of all cancers that we see at the time of diagnosis. Particularly stage 4 breast cancer is defined as being incurable, And nowadays we see so much advance of therapy that what we had previously before, a number of these treatments are now changing, which I will highlight throughout the conversation today. So in terms of treating metastatic breast cancer, the aims of the therapy are really to prolong the time of progression, in other words, from one treatment to the next. The second is to allow for prolonging survival and improving quality of life as well for patients. So when we talk about this disease, we're really looking at a systemic disease that requires multitudes of different therapies. And much of what we're doing is to not just reduce tumor burden, but also maximize survival and also improve quality of life. And hopefully we'll have the presentation here in just a second. Of therapy, particularly for ER-positive, HER2-negative disease at the moment. Currently, we're looking at a number of hormonal agents that were used in the past, particularly tamoxifen, that was initially allowed in 1977 when it got its approval, and subsequently aromatase inhibitors, which were approved in the late 1980s and early 2000. And then essentially estrogen blocker, fulvestrant, which was released in 2002. Most recently, we're looking at CDK4/6 inhibitors, which are now part of the advent of therapy, which allow us to combine aromatase inhibitors as well as estrogen antagonists with its combination. And most recently, this past year, we've had the advent of a PI3 kinase inhibitor, such as alpelisib, which also has been a part of our armamentarium, particularly in the second and third line setting. The CDK4/6 inhibitors, as we've now used them predominantly, have been utilized with an aromatase inhibitor. And in the first line setting, what we've noticed is that there has been a significant progression-free survival of approximately 25 months. Previously to that, the average length of survival in these studies was approximately just over 1 year. And since the advent of these three drugs, particularly palbociclib, ribociclib, and adibociclib, which all have different toxicities as well, there has been a significant improvement in survival, both in progression and overall survival. And this has led to approval for all three drugs in the first as well as second line setting. Excuse me, 1 second. Now, with the second line benefits we've seen in these drugs, particularly with the advent of fulvestrant, we have seen the utilization of these drugs, particularly in the PALOMA studies, where there has been even patients that have gone through a first line treatment with endocrine therapy, a significant benefit up to approximately 34 to 35 months with all three drugs being utilized, either with an aromatase inhibitor or fulvestrant itself. Now, the question that has arisen since the utilization of many of these drugs is, can they be utilized separately or in combination with palbociclib, and which is really the best combination that we've seen? Now, the PARSIFAL study was a study where they used an endocrine backbone of palbociclib, and the second agent was either fulvestrant or letrozole. And in that study, they actually tried to see if there was a significant difference between the two arms. And based upon that study, there was no significant difference. And the overall progression-free survival was identical at 54 months. So essentially, one can use any endocrine backbone with these drugs and still achieve a similar benefit for women. Now, the other question that we've raised is it similar or not to endocrine therapy, particularly when we're utilizing a CDK4/6 inhibitor with an endocrine agent like letrozole? or fulvestrant. And so there's the study referred to as the PEARL study, which was looked at both young and older patients. In that study, they tried to determine a difference between chemotherapy versus endocrine therapy. And based upon this study, there was no significant difference. Thus, this essentially showed us that the utilization of chemotherapy, both in first and second, was not necessary in patients with endocrine disease, that the overall survival and progression-free survival was quite similar. Now, so the questions that still, let me just kind of move forward here and let me just make sure that everybody can see the screen. Great. So basically, let me just kind of touch base here with everybody where we were. So this is the PARSIFAL study, which I originally talked about, which essentially is looking at a second endocrine backbone to see if there's a difference when we add another drug to one of these CDK4/6 inhibitors. And based upon this study, which enrolled approximately 500 women, there was actually no significant difference. So essentially, utilizing really any drug with these partner drugs produces the same overall benefit that we've seen. Now, the other thing I was just discussing was the PEARL trial, which looked at chemotherapy versus these combinations. And is it as good as chemotherapy? And based upon these two trials, the PEARL, which was done on postmenopausal women, and the Young PEARL trial, which was done on premenopausal women, approximately 300 patients in each study, there was no significant difference. So essentially, the question really now pertains to where to use chemotherapy in patients with endocrine positive disease. As we can see, oral combination of treatments with endocrine therapies are just as equivalent to utilizing chemotherapy. So this raises the following questions and certainly gives us a better idea of how to use these drugs, particularly in hormone-positive, HER2-negative breast cancer. One is that we know that combining these drugs with hormonal therapies has now become the standard of care. And this allows us to both improve progression-free survival, which allows to delay the time from the disease progression of the cancer, as well as improve overall survival for patients with endocrine disease. And from the PARSIFAL trial, we know that there's no significant difference in terms of benefit in the endocrine agent that we utilize. Unfortunately, at the moment, we don't have a clear biomarker to note which women will actually have significant success and which women will actually have a recurrence early on. We also know, based upon the PEARL studies now, that there are similar outcomes for patients with either receiving chemotherapy or endocrine therapy, which gives us a much more advantage of using endocrine therapy in the first and second line setting. The challenges, however, that we're facing at the moment are the mechanisms of resistance. There have been a lot of hypotheticals here in terms of what to use. One of the things that we have been continually doing now is assessing women for possible mechanisms of resistance. One of the mechanisms that we've recognized is the PA3 kinase mutation, which I'll talk to you about in a minute. The other thing is, can the role of these inhibitors continue beyond first line or second line progression of disease? Unfortunately, this question is still unanswered. And what are the biological rationales to restore sensitivity? Are there other drugs or other techniques that we can use to allow sensitivity to restore to these agents? Now, in terms of the mechanism of resistance, the PI3 kinase mutation actually sits on estrogen receptors at the internal cell. This allows for specific isolation of the AKT mutation, and then this triggers further cell production and allows the cancer to survive. One of the things that we've now developed is a mutation to the PI3 kinase, which allows us to overcome the resistance to this disease. The clinical trial referred to as a SOLAR-1 study, which was recently published, approximately 600 women were subsequently randomized with the PI3 kinase mutation, and those that did not to receive alpelisib, which is a PI3 kinase mutant inhibitor, along with fulvestrant, which is an anti-estrogen. Based upon this clinical trial, patients were randomized based upon the mutation or not having the mutation. Overall, the progression-free survival in patients that did have the mutation showed significant benefit of approximately 11 months versus 5.7 months for the fulvestrant arm. So thus far, the FDA has authorized the utilization of this treatment for patients with the PI3 kinase mutation following first-line endocrine therapy and failure of such therapy, which will allow us to overcome mutation resistance. Overall, what we've seen in adverse events for this drug particularly are elevated blood sugars, rash, and stomatitis. So essentially, up front, we need to monitor blood sugars for patients, as well as discuss potential rash, nausea, and vomiting that can occur. And usually we check almost every week while they're on this treatment. In summary, based upon this particular disease process, we know that CDK4/6 inhibitors have dramatically changed outcomes both in survival, response, and progression-free survival. Similar outcomes to chemotherapy. They have become the first-line standard of care. And the PI3 kinase mutations, with the utilization, we know that this causes resistance in patients that have already received a first-line treatment. You can utilize alpelisib with fulvestrant that has shown a doubling in the overall progression-free survival for women. Unfortunately, however, we still have a number of questions that are related to women that do have resistance to this disease and how to overcome it moving forward. So there's a number of clinical trials that are still in process that we are waiting on at the moment. Now, moving on to HER2-positive disease, which has been I think a great advent in terms of where we are with breast cancer today. Approximately 30% of women will still have HER2-positive breast cancer at the time of diagnosis. The great thing that we've encountered now is that we have 7 drugs available to us in the market. And many of these drugs have just become available to us in the past 3 years. For the past approximately 10 years now, we've had Trastuzumab, which blocks the HER2 receptor, and Pertuzumab, which was developed approximately 7 years ago, which blocks on the HER2 and 3 receptors. These are both targeted antibodies that allow cell-to-cell to be recognized and allow the immune system to target these cells and eventually destroy these cancer cells. What we also have on the market now is TDM1, which was developed approximately 7 years ago, which has a similar compound structure to Herceptin, but allows the delivery of a chemotherapy payload to the specific cell itself. This past year, we've had the introduction of TDX2, which is Trastuzumab deruxtecan, which has also shown significant benefit in the second-line setting and allows for a delivery of chemotherapy to the cell specifically rather than systemically to the body. Now, within the oral agents that are available for HER2-positive disease actually work just below the cell surface at the PI3 kinase level, and these drugs basically shut down the cell proliferation and cause cell destruction by themselves. And these 3 drugs, Lapatinib, which was available in 2008, Neratinib, which was available this past year, and Tucatinib, which was just released this year as well. So I'll talk a little bit about these drugs and how they've affected the survival as well as the outcomes for patients with HER2-positive disease. What we know is, based upon the CLEOPATRA trial, this was done approximately 5 years ago, and recent results were resubmitted this year at the 8-year landmark study. This study was a landmark study as it changed significantly the overall picture of breast cancer and that is being treated for HER2-positive disease. With the addition of Pertuzumab to the Trastuzumab and Docetaxel backbone, there was a significant benefit of approximately 17 months in median survival, and at the 8-year survival mark, there was greater than 14% of women still alive that were, unfortunately, as you can see, only 23% were alive previously on the previous arm. So this had a significant benefit and continues to show benefit in women with first-line treatment. But unfortunately, as we know, women do still progress off first-line treatment, and therefore second-line treatment options still need to be available. Progression after the first-line treatment, 2 studies were originally released, which were the EMILIA study and the THIRESA trial. These both looked at a compound called TDM1, which is the delivery of a Herceptin molecule with a chemotherapy backbone to it, which allows for cell death. Based upon these 2 clinical trials that were compared to either physician's choice in the THIRESA study or Lapatinib and capecitabine in the EMILIA study, basically showed a significant improvement in overall and progression-free survival, which basically gave this drug second-line clear treatment of choice. Unfortunately, though, results from these trials did show that approximately 15 to 30% of women unfortunately had intracranial metastases, and this drug, TDM1, does not penetrate the brain barrier. So there was a significant concern for women following this treatment, following this drug trial, of where will we go with the next line of treatments. What we do know is these small oral molecules, lopatinib, tucatinib, as well as neratinib, do penetrate the blood-brain barrier. And this gave us an advantage, at least, to see if one of these drugs would work in this setting, particularly for HER2-positive breast cancer patients, where there's a higher risk of intracranial metastases. So the current approach right now in sequencing is first-line treatment with Trastuzumab and Pertuzumab based upon the CLEOPATRA study, the EMILIA and THIRESA trials, which has given us TDM1, and now I'm going to present to you the HERZCLIMB study. So the HERZCLIMB study utilizes tucatinib, which is an oral selective molecule for HER2/neu. This is a molecule which you can see has a much more specific cellular sensitivity to the HER2 receptor. We know based upon the other two drugs, this has a decreased level of skin sensitivity and diarrhea. And like the other drugs, it penetrates the penetrates the CNS extremely well. The HERZCLIMB study, which was published this year, looked at it as the first study, patients with active brain metastases, the combination of tucatinib with Trastuzumab and capecitabine versus Herceptin and capecitabine alone. This was a study that looked at approximately 600 women. It was randomized 2-to-1 for the tucatinib arm to the placebo arm. And based upon this clinical trial, the progression-free survival improved by approximately 2 months. The 1-year survival improved by almost 20%. But more importantly, when we looked at the overall survival, this was the first time we've seen in the second-line setting a significant 2-year survival advantage of approximately 21 months and 45% of the women being alive at 2 years, and the intracranial activity being significant. Where the Herceptin had no specific activity within the brain, the tucatinib did, and showed a 35% improvement in progression-free survival, as well as a 30% improvement in overall survival in women with active brain metastatic disease. So this really formulates now a new line of treatment in the second-line setting, and many of us have gone to this regimen based upon these clinical trial results from HERZCLIMB. So we move on to the next slide here.
Dr. Kahn, it's Eileen.
Yes.
Can I jump in and ask just one thing?
Yes, absolutely. Go right ahead.
As you go through your slides, if there's a common name for the drug, I had a question.
I will.
To say to reference that as well, if you don't mind. I just had to throw that in.
No problem at all. So absolutely. So the common names for Trastuzumab is Herceptin, Perjeta for Pertuzumab, and the TDM1 compound, which has formed the backbone of second-line treatment, is referred to as Kadcyla. The new drugs, tucatinib, is now referred to as Tukysa, and lopatinib has been on the market for quite some time, but that is referred to as Tykerb, and Nerlynx is neratinib, and I'll get to those drugs in just a minute. And I'll certainly mention the generic as well as trade name drugs too. So moving on so let me go on to the approval here. Tucatinib essentially was approved for patients with unresectable metastatic HER2-positive breast cancer with active brain metastases, as well as any patient that has gotten through one line of treatment. The administration is approximately 300 milligrams twice daily, with or without food. It needs to be monitored almost on a weekly basis for liver functions. As well, clinical management needs to be done approximately at least every 3 weeks after initiating the drug. Now, moving on to the next drug, which is this drug, which is a basically a similar drug to TDM1 or Kadcyla. Trastuzumab deruxtecan, which is DS8201, this drug recently became available, and we'll be seeing the market fairly soon. This drug actually delivers a chemotherapy payload within the cell and also allows for other cells to die as that chemotherapy permeates from cell to cell. So this is something that is really new in development. We had not seen a drug like this previously before. The drug study called the Destiny study looked at this drug in comparison to what we had in second line or TDM1. And this was an open label phase 3 clinical study, approximately 500 patients, randomized 2-to-1 to the Trastuzumab deruxtecan arm. The overall benefit in progression-free and overall survival was slightly better than the TDM1 compound. Unfortunately, with this drug, there's still not a name for this drug yet, but fairly soon there will be, and this drug will be available on the market. It's already gained FDA approval based upon this clinical part of the trial, and the administrating dose is approximately 5.4 milligrams per kilogram. It is very similar to Herceptin and Kadcyla. Essentially, you will need to have the heart function monitored throughout the treatment. The other concerning issue with this drug is potential pneumonitis or inflammation of the lung. Approximately 8% of patients did develop that on the trial, and this is something that we have to monitor very closely for. There was, unfortunately, disease progression within the brain. We do not have any clinical data as this compound enters the brain. So, unfortunately, the only real drug that we have for brain penetration remains tucatinib in the second line, and in the third line, we have all three: neratinib, lapatinib, and tucatinib. So moving forward with neratinib, which is Nerlynx, this drug is a irreversible binder just underneath the HER2 receptor. It does cause significant amount of diarrhea, and Imodium along with Lomotil is utilized within the package insert, as well as when the package arrives to the house to the patient that we start that together. Now, the clinical trial that was published here in 2020 looked at this as a third-line agent in comparison to lapatinib and capecitabine. This was also a 2-to-1 randomization study. It looked to see the overall survival and progression-free survival difference with this combination in comparison to what we had in third-line setting. Based upon this clinical trial, there was a significant difference in progression-free and a 2-month difference, approximately 2-month difference in overall survival, which led to its approval in the third-line setting so that we would have significant more agents available to us in the second and third-line setting. And essentially, the approval that came in February of this year allows the combination with capecitabine in patients with advanced or metastatic HER2-positive breast cancer that have received more than 2 lines of treatment. Now, the current approaches that we have after first line is both TDM1, which is the Kadcyla compound, tucatinib, which is Tukysa, which is utilized with Herceptin and Xeloda. The support in terms of how to sequence each of these drugs is still not available at the moment because these drugs were not studied against each other. The patients that received TDM1 therapy, the patients that did receive tucatinib had a significant improvement in brain metastases reduction, as well as overall survival. What we also know is that where to place this drug right now is still a question, but we do use it in the second-line setting. Third-line approvals have been for Trastuzumab deruxtecan, which I explained to you, as well as the potential toxicities of pneumonitis, hepatotoxicity, and lung disease. Neratinib and capecitabine, which does have a significant issue with diarrhea, and tucatinib with Trastuzumab and capecitabine based upon the original HERZCLIMB study. Unfortunately, we still don't know how to optimally sequence these, but we do have a number of agents now available to us within the second and third line setting now. The other new agents that are now developing, which was just released from the San Antonio Breast Cancer Conference in December, is a new drug called Margetuximab, which is a novel antibody similar to Trastuzumab, which allows for greater binding affinity to the cancer and allows to have the immune cells to attack the cancer in much more preferential fashion. So the SOPHIA study, this was utilized Margetuximab versus Trastuzumab in the third-line setting. Approximately 536 women were enrolled on this study. This was given every 3 weeks at 15 milligrams per kilogram in comparison to Trastuzumab, which was given initially with a loading dose at 8 milligrams per kilogram and then 6 milligrams per kilogram. Unfortunately, Margetuximab does not have a trade name as of yet, and as you know, Trastuzumab is Herceptin. The overall survival and progression-free survival was quite similar. Essentially, both drugs were quite similar, and there was no preferential difference between the two. What we do know is that in patients that have a CD16 mutation, there was a significant benefit, and thus this has alerted us to check patients now for this potential mutation, as they may have a greater derived benefit in the third-line setting with this agent rather than Herceptin alone. Now, the other thing that's coming up now is patients that have low HER2, and this may be a separate disease, which was also presented in San Antonio this year. And there may be some issue with development of HER2 low, which approximates approximately 46% of hormone-positive disease and approximately 26% of triple-negative disease, where Herceptin may prove to be of some benefit. And actually, let me move on to this clinical trial. The MonarcH study actually looked at some of these patients within this study, and Abemaciclib has been utilized in the hormone receptor positive patients, but this also looked at also looked at Trastuzumab with chemotherapy as an additional arm. So right now, what we know based upon this clinical trial is that the survival benefits are approximately the same. So this is still something we're continuing to explore in patients that don't have true HER2 positive disease, but may have a variant of HER2 positive disease that's positive on the immunohistochemistry, that there may be some possibility of using Trastuzumab there as well. So this is something that's going to continue to develop over the next year or so. And in summary, essentially, we know with HER2 positive disease that there are multiple agents. Tucatinib, which has shown significant benefit in brain metastases. We also know that we have the availability of Trastuzumab deruxtecan to help with response and progression-free survival. And newer agents are only upcoming, particularly with Margetuximab. We have that available in the third-line setting based upon the SOPHIA study. And some of these drugs will now become more readily available within the market, probably within the next 2 or 3 months. Now we'll move on to triple-negative disease. Let me just make sure that there are no questions. Okay, great. And so we'll move on to triple-negative disease here. So unfortunately, this is a disease that we're still searching a target for. There have been a number of developments within this disease, particularly immunotherapy treatments that I will highlight for you. Despite all the advents that we've had in this disease, based upon recent studies, this is a Medicare database evaluation that I'm showing here, the recurrences for this disease compared to other diseases continues to happen within the first 5 years. And the hazard rate basically showing how many events that occur within the first 5 years. And unfortunately, with triple-negative disease, this is still a very difficult disease to treat because of the number of occurrences that occur very early on. Now, what we do know in this disease particularly is that it has the potential to be very immunogenic. So in other words, there may be within the early as well as advanced setting lymphocytes within the cancer cell that we can target to help us defeat the cancer. And so this slide essentially is kind of showing us the number of immune cells that are within the first line as well in the second line setting. But unfortunately, as we continue to progress, there's less and less lymphocytes within there to not allow us to target the disease as much. Now, the initial trials that were done with these agents were in the first line setting. The first of the trials was the Impassion 130 study, which allowed us to utilize Tislelizumab. The name of this drug is Tecentriq, and this was given along with Abraxane or nab-paclitaxel in comparison to nab-paclitaxel. This was looked at in a randomized fashion. There were approximately 500 patients on this study, and the endpoints on this trial were to see if they would benefit in terms of progression and overall survival. All patients on this study had metastatic or incurable disease. Based upon this trial, the overall survival was improved by approximately 5 months. And then the patients that had positivity based upon the PD-L1 assay, which allows us to tell, which gives us an idea how many actual lymphocytes are there, which will allow us to give the drug in a more responsive fashion. This provided a 10-month median survival. Based upon this clinical trial, the FDA approved this drug for patients with triple-negative disease that had positive PD-L1 and that fit into this subgroup. Now, the other study that was done was the KEYNOTE-355 study, which looked at pembrolizumab, which is Keytruda, given every 3 weeks along with chemotherapy of choice. That chemotherapy could either be nab-paclitaxel, paclitaxel, or gemcitabine and carboplatin. This was compared to the chemotherapy arm, approximately 2-to-1 here, 566 patients on the pembrolizumab arm and 281 patients on the chemotherapy alone arm. Similar endpoints, patient population was quite similar to the IMpassion study as well. Based upon this clinical trial, the overall progression-free survival in the entire population was quite similar, 55% alive at 6 months, without progression at 6 months, and 29% of patients without progression at 12 months, and the overall progression-free survival was 7.5 months to the pembrolizumab arm or the Keytruda arm, and to the placebo arm was 5.6 months. For the entire Intracranial population, there was not a significant benefit. However, when they looked at patients that had positive PD-L1, just barely made it by just greater than 1, there was a survival advantage of approximately 2 months in the progression-free. The patients that had a much higher predictive score based upon the CPS or the PD-L1 assay for this drug, there was a approximate 4-month median difference in progression-free survival. So essentially, the FDA approved this drug as well based upon the PD-L1 assay. So essentially, all triple-negative patients that have PD-L1 positivity can receive either pembrolizumab or Keytruda or Tecentriq based upon the PD-L1 assay that they've used. And based upon the positivity, the greater the positivity is, the greater the response to the drug and the longer the duration of survival. Unfortunately, as we know in this summary slide, I just wanted to conclude here, which is that monotherapy with chemotherapy alone is very modest. The addition of the new agents now has shown a significant benefit for patients with triple-negative breast cancer and positive PD-L1. Unfortunately, we do not know how to combine these drugs outside of the chemotherapy backbones that we've utilized. The majority of them were taxane-based, such as Abraxane or Taxol. The actual sequencing of the treatment is still under development, so there's a number of clinical trials now looking at maintaining these treatments with other lines of treatment along with other additions of treatment as well, and looking at further potential block of the MEK kinase inhibition as well as the ATK inhibition to see if we can induce greater responses with these agents is still under development as well. So let me open up to questions. So let me just, I'll stop sharing here if I can. Wait 1 second.
So thank you, Dr. Kahn. And it's Eileen again. And I am been monitoring the chat box. And so, of course, at first we had a couple of technical difficulties. And thank you, Dr. Kahn and Chris and Melanie, for getting us through all of that and getting our slides up. And so you presented an awful lot of material. And so I'm sure everyone's digesting some of this. But if there are questions, you can type into the Q&A box. And while we're waiting for that, Dr. Kahn, would you like to revisit any of the comments at the very beginning? Well, just as we're kind of getting back into things. And so if there was something that perhaps was one of your first slides to trigger. And I'm still looking for questions.
Yeah, I think that, you know, the amazing thing that we're seeing more and more now, particularly for HER2 positive. Yeah, sure, go right ahead. would you please speak to the significance of 6 TNBC molecular subtypes and treatment options? Yes. So there are a number of, as we know within the triple negative subtype, the luminals, basaloid subtypes, we do know that there are significant subtypes. The other thing that I didn't mention here also was the genetic correlation with TNBC to the BRCA mutation. So because of time's sake, I didn't talk about the recent approval of the Talzaraparib as well as the previous utilization of olaparib based on the Olympia trial. So there are significant molecular subtypes within the triple negative, which we're still trying to look at. And one of the things that we're really interested in to see if there's specific molecular targets within the luminal A, luminal B, and basal subtypes as well. Unfortunately, what we don't have right now, which we have in ER-positive disease, is a means to clinically signify what they mean to us therapeutically. So what I mean is that, where we have the introduction of now assays to tell us how well estrogen therapy or anti-estrogen therapy will work, we really don't have something specific for triple negative disease. So although these subtypes exist, we're still trying to better elucidate how to treat them one by one. But great question.
Okay, thank you. And so I'm still monitoring. I'm still monitoring. I haven't seen any other questions come in yet.
So the next question here is about genetic monitoring. So normally what I would do in the first line portion of patients that have metastatic disease is I actually go ahead and run a foundation assay or a molecular assay for them to see if there's some within their cells a somatic mutation, which could be for BRCA. In other words, it just exists within their cells. I also have them see genetic counseling to see if there's germline mutations as well, which could help us down the road in terms of treating them with potential options of treatment that can be available to them. Yes, so the next question here is Nerlynx, which is neratinib. So based upon the Extenet study, neratinib is currently being used as maintenance therapy for HER2-positive patients following chemotherapy and Herceptin, Perjeta, and possibly Kadcyla. These patients will receive this for approximately a 2-year course as utilizing this with stage 1 and 3. Sorry about that. We got cut off there. Did I answered a neratinib question? Did everyone hear that or no?
Towards the end, we lost you.
Okay, no problem. So one of the attendees did ask about neratinib being used for patients without metastatic disease. So this drug, also called Nerlynx, was actually approved based upon a study called the Extenet trial, which was given to patients as maintenance therapy, stages 1, 2, 3, that had completed their adjuvant chemotherapy or chemotherapy after surgery, or may have had neoadjuvant chemotherapy before surgery and then had Herceptin or Perjeta or Kadcyla following their surgery. So these patients had this treatment for approximately 2 years. So this is approved. I do use it within my practice, but the number of women that want to use this treatment are not very high. The reason being is that the overall benefit was approximately 2.2% in terms of survival benefit at the end of the study. Furthermore, the diarrhea is still a significant issue with this drug, and so it becomes dose limiting, as well as not so many women want to take the treatment because of just the level of diarrhea that they experience. Hopefully that answers that question.
I think we got the entire answer that time. Thank you. Yes, I appreciate you going back.
Great.
Okay.
So the next question is, can it be difficult for patients to get connected with clinical studies? So we have approximately right now 35 clinical studies open at St. Peter's. I'm more than happy to provide my email to everyone if they are interested in enrolling in a clinical trial for breast cancer, for metastatic breast cancer, as well as neoadjuvant and adjuvant therapy trials. We do have them available to you. We also participate with clinical trials with Memorial Sloan Kettering as well as Dana-Farber. And so if anyone is interested to learn more about some of these clinical trials, please feel free to email me, and I'm more than happy to provide my email to everyone that's participated today. So the next question is long-term use of hormone treatments for ER-positive breast cancer associated with subsequent presentation of TNBC or triple negative breast cancer. So there have been some hypothetical suggestions as well as some long-term studies that were done at MD Anderson that I'm aware of. It did show that there were different subtypes of cells that start to grow with long-term utilization of these agents that block estrogen receptors. How they're triggered, what happens intracellularly is still very hypothetical, but there are some data that is showing that we don't have long-term randomized data yet, but hopefully we'll see, and hopefully we'll also be able to elucidate some mechanism as why that happens as well.
Okay, thank you, Ruth.
Great question. Eileen, everybody's well prepared today, I have to say. I mean, the questions that are coming in are excellent questions.
Well, so as you know, Dr. Kahn, we have, since this is the 6th in our series, many of the participants have been on at least some of our other talks. And so
wonderful.
Every single time come in with really excellent questions. We also have a number of people, as well as survivors. We've got a number of other medical professionals, whether it's navigators, other practitioners and whatnot. So they are going to come in with a body of knowledge. And so as you help us put some of these pieces together and get an appreciation for what this diagnosis will look like in terms of the treatment options going forward, which seems to have, we've had a landslide of developments happening in some of the studies you point out to, as well as, where are we going in the future? What does this look like?
Absolutely. Absolutely. And I think the future really is going to be where we start to elucidate some of these other mechanisms of resistance, more and more. So the next question is, you mentioned estrogen receptor drugs. Is there any information about the risks of long-term, let me see if I couldn't get the rest of the question there, I apologize, but the long-term utilization of these.
Okay.
Yeah, please.
You mentioned estrogen receptor drugs. Is there any information about the risks of long-term, this is 10 years or more out, letrozole use or other aromatase inhibitors? Good question.
So there are some studies that are still ongoing on these particular topics where
Dr. Kahn, you just froze for a moment, and so you'll want to start your answer.
Some of the question was particularly in women that let's say have very low parking. Yeah, sure. Yeah, can you hear me okay? Give me 1 second. Can you hear me okay or no?
Yes, now I can.
Okay, perfect. So, we don't know exactly some of that information, but those studies are still ongoing. We know that we're still looking at anti-estrogen therapies for greater than 10 years.
Okay. Well, thank you. Yes, we did. I think we got most of that answer. And so with that,
good. Sorry about that. The connection might be still a little off there.
Well, it happens. And so I think you've done great. And we've gotten through, I think, all of the questions that have come in. I'm just going to check the chat one more time. I don't see anything else in the Q&A. You've answered all of those. And so we are going to be done with that piece of it. And I am going to say thank you, Dr. Kahn, for sharing some insight here and some information. We will make the recording of today's presentation available. But now I'd like to invite Melanie McCulley to say a few words and wrap us up today. Thank you.
Hi, everybody. Thank you so much for hanging in with us. I don't know if the snow in the surrounding area is causing some issue today, but we appreciate your patience. Thank you so much, Dr. Kahn. We really appreciate your presence and being here and talking about this difficult topic. We have a lot of clients who are dealing with this issue, and I appreciate all that you have in terms of knowledge. And I really encourage people to reach out to Dr. Kahn, especially about clinical trials. I know a number of people have expressed difficulty getting connected with them. So He's a great resource, and please utilize that. It's hard to believe today's the last of our 6 Women's Health Conference series. I know some of you have been to all 6 of them. We appreciate that very much. If you were able to attend one, we obviously appreciate that as well. As Eileen said, we have put at least 5 of them will be available. They're on our website. This one will be in a day or so, but they're on our website under the portion that talks about the Women's Health Conference on our website. So you click on that, look at each program description, and at the end of that, you'll see a link to the program so that you can rewatch them if you're interested. So we thank you. You know, this has been an interesting year, obviously. You know, we always do this conference as a day-long event. We sat with the advisory board figuring out how do we do this, how do we provide to you a very quality program with the kind of caliber of speakers we've always provided you on the topics that you're interested in, and made a decision to spread this out from October until the end of January in these 6 different segments, and we've gotten really great feedback from you. We know that's not the same as being together, getting to hug your longtime friends and see all of us and say hi in person, but on the positive, we've noticed an increase in our engagement in many areas of To Life during COVID because we have some of the barriers have been removed for women. People who have transportation issues, who live in some of the 10-county area we serve that are further out and have challenges getting to us or participating, people with childcare challenges, or who simply are in treatment and not feeling well, have been able to attend programs and support groups, even if from their couch or their bed sometimes. But the important thing is, rather than be isolated or not be connected, they've been able to be a part of our community as well. So we look for the blessings, the opportunities in the challenges that we've had in this last year. So to that end, we continue our support services, wellness programs, both virtually, by phone, by email. So you can reach me if you've tried to. I'm very responsive, so keep reaching out to me. I'm here if you need. We also are continuing our boutique services by appointment. So Alice and Connie and Risa all stand by to help you. Let us know if you need those services, and we will continue to stay in touch. We appreciate your participation and support so very much. And we will be sending an evaluation later this afternoon. Bear with us on the technology. We have certainly done what we could. There's only so much we could control, and what we could, we did for you. So we thank you for your patience with that and for your feedback. And I look forward to seeing your faces, whether on Zoom or soon, hopefully in person. So thank you, everyone. Thank you again, Dr. Kahn. I do want to thank the advisory board, who has been instrumental in pulling together this program. Eileen, thank you so much. Sue Buell, who is our community outreach person, has been excellent getting the word out about this. And a special thank you to Mara Ginsberg, our founder, and also to Chris Breton, who our assistant director, who has been our technology person through these webinars and really rose to the occasion. And I thank her very much. So have a great day, everybody. We'll see you soon.
Thank you. Thank you, Melanie. Thank you, everyone. Have a great day.